Okay, we need to make sure that we're localized. We don't want our forces at the hip. We don't want our forces in the lumbar spine. We want our forces at the SI joint. So I come from below up until I feel the innominate just start to move. How do I know that's happening? The best place to feel SI motion is in the sacral sulcus. That is that space between the PSIS and the base of the sacrum, just medial to the PSIS. That's where my fingers are. So what am I getting first? I'm getting the hip. And then I start to get to the point where I just start to feel motion arrive. I stop. That is the feather edge. Back up a little bit and start again. Make sure I'm just getting the very beginning of that motion right there. I'm just starting to feel motion with my fingers coming into the SI joint. At that point, I'm going to ask for an isometric contraction of the glute maximus. Because it's anteriorly rotated, I'm going to use a muscle effort to derotate it back into its neutral, normal, anatomic alignment. So I'm going to ask him, I'm going to try to push your knee up to your chest. Resist me. This is not 10 out of 10. This is sub-max, about 4, maybe at most 5 out of 10. Ready? Hold against me. 1, 2, 3, 4, 5, 6. Relax. Let it relax. And then I go to the new barrier. I go to where I feel it just start to move again.
Gain motion from that feather edge first.
Yep. Yep.
This is considered a mobilization.
This is, yep. I guess you could say that. Mobilization through muscle energy. Okay. Goodbye that. I go to the barrier. 1 second. I go to the new barrier. Again, don't let me move you. 1, 2, 3, 4, 5, 6, and relax. 2 or 3 times, I take it up a little further. So realize that unlike in this room where you're not anteriorly rotated, in a patient that we make this diagnosis, we're going to start in a position of malalignment and then bring them back to neutral. That's our goal. We don't want to take them in the other direction. We want to just take them so that the dysfunctional side lines up with the normal side. Everything is properly balanced. Okay. All right. Okay. Could someone get the skeleton for us? Be so kind, Dr. Frito's office, and I'll show you on there. As I said, I'm monitoring in the SI joint. I'm using the lower limb to move first at the hip and then past the hip to the innominate. And once I feel the innominate start to move on the sacrum, I stop. That's the feather edge. I don't want to go too far. At that point, I'm going to ask for an isometric contraction of the hip extensors. Some hamstring and probably more glute max. There's a lot of knee flexion here. At that point, a few things are happening. One is that if you look at that chart's description point by point of what's happening with an anterior innominate rotation, the iliopsoas is either facilitated and or short. So when I have him contract his glute maximus, what am I doing to the hip flexors? Down regulating them, decreasing their tone. So if they are somewhat hypertonic, we're relaxing them through reciprocal inhibition. That's a good thing. And the other thing is that we're contracting the glute maximus in reverse action. In knees, you're used to thinking about a stable origin and a mobile insertion. I'm doing the opposite. I'm stabilizing the insertion, moving the origin. So when I do that, and the glute maximus shortens, it'll pull on the proximal side of the equation and rotate the innominate posteriorly. So I'm getting a neurophysiologic effect, inhibiting tone in the hip flexors, and I'm getting a mechanical effect, rotating the innominate from an anteriorly rotated position back into neutral. And then I reassess. Standing flexion, which one would be positive with the anterior innominate, the stork or the reverse stork? Stork is positive. The innominate is anteriorly rotated. It lacks range in posterior rotation. So positive stork. Could be upper, could be lower pole, could be both. All right. Let's have you on your side, towards me. I'll give you a couple options. Side lying, another something you can try a little close toward the end. Now, I'm going to try to isolate motion to the SI joint, straighten the bottom leg. I'm going to take him into rotation from above. Iliac crest, 4-5. Go down to 5-1. I'm going to rotate him down to 5-1. I'm going to lock up 5-1. I don't want it to move below that. But I'm going to try to, through Fryet's third rule, which is if I introduce motion in one plane, rotation, you're going to get some coupling with side bending as well. I'm going to limit motion in that part of his spine. I'm taking the slack out of the lumbar spine. So now when I move him into the lumbopelvic hip area, it's more likely that I'm not moving the lumbar, and more likely I am moving the SI. So I'm taking his top leg, I'm palpating in the joint, PSIS, medial. Phil Greenman says medial and a little bit caudal. Right in that space. I'm coming in from below. It's a domino effect. I'm at the hip right now. I'm not in the pelvis yet. I'm at the hip. I'm coming over. I'm coming up into the pelvis, and there. I'm just starting to feel movement. That's the feather edge. You want to just introduce it. Muscle energy is a very gentle technique. You're not locking anything up. You're just introducing. At this point, I'm going to ask him, I'm going to attempt to move your knee up to your chest, push down in the other direction against me. Meet my force. Ready, go. Meet my force. 1, 2, 3, 4, 5, 6. Relax. Let it relax, and then take him up a little bit more to the new barrier. I'm coming to the new barrier. So I got a little bit of range. I'm getting more motion, and now I go to the next area of resistance. Again, don't let me, so with my upper thigh and my hand, I'm trying to move him into hip flexion. He's moving against me into hip extension. So primarily, glute maximus, some hamstring. Ready? Don't let me move you up, move down, meet my force, no more than 5 out of 10. 6 seconds, relax, and go a little bit further. 2 or 3 times. And then I check. Standing flexion, stork, check his landmarks. I can check sitting, supine, prone, standing. See if I've made a difference. Asymmetry, range of motion. We can even check tissue texture. Things like the sacrotuberous ligament should be less taut. I do mention, in terms of the charts, I mentioned a little bit about the hips. With an anterior innominate rotation, I mentioned last time that the innominate will actually flare a little bit. It'll tend to internally rotate the hip. So, as part of your A, you could check just quickly internal and external rotation. And with the anterior innominate rotations, you'll find on that side, on the side of the anterior innominate, they're a little bit limited in external rotation, because the acetabulum tends to move internally with the inflare. And after you correct it, then it should have normal range. External should be free now. On the stomach, the other thing you can check. The other thing you can check. Remember I mentioned the coccyx. You can check the coccyx will pulled over by the sacrotuberous and sacrospinous. You can also check under T sacrotuberous ligament. So that's running from the ischial tuberosity up towards the ILA of the sacrum. When it's really taut, you can strum over it, and it's really hard, really dense, tight, compared to the other side with a posterior nominate, lax with an anterior nominate. So if I just corrected an anterior nominate, I wouldn't expect to feel a whole lot of difference. But when we correct the next one, which is the posterior nominate, I should take that really hard and taut sacrotuberous and relax. So you check your A, you check your R, you can check your T. All right, thanks, Chad.